All right, I will invite everyone to come in quickly and take your seats so that we can get started with our Quickshot session. And as a reminder to all, these sessions are very quick. Each presenter has only 3 minutes, and so oftentimes we don't actually have any time for a question. The moderators will monitor whether we're going to be able to fit in one quick question or not. In the interest of time, I will introduce our moderators for our Quickshot session tonight. Dr. Erica Carlisle is an assistant professor of surgery at the University of Iowa, and Dr. Nicole Kuss is a general surgery resident at the University of Maryland and currently a research resident at the Children's Hospital of Philadelphia.
All right, well, thanks for joining. We'll welcome our first presenter, Dr. Keene, who will be presenting the impact of cumulative opioid exposure in the first year of life on neurodevelopment among high-risk infants. She's coming to us from the Children's Hospital of LA.
All right, thank you so much for the opportunity to present. These are our disclosures. Work in the 1980s showed that infants exposed to painful procedures experience acute physiologic responses and increased morbidity. Opioids were found to reduce the poor outcomes associated with painful exposures, and today greater than 200,000 infants are exposed to opioids in the US annually. More recently, however, increasing days of opioid exposure has been associated with impaired cerebellar growth, intraventricular hemorrhage, and developmental disability. So we sought to investigate the relationship between increasing doses of opioid exposure within the first year of life and neurodevelopmental outcomes. So we conducted a single-center retrospective study and built a cohort of high-risk infants less than 1 year of age admitted to our institution between 2009 and 2020 using ICD-9 and 10 codes for the diagnosis categories listed on the slide. High-risk infants were defined as those with neonatal morbidities that lead to increased need for developmental care following discharge and high-risk infant follow-up clinics. Our exposure was cumulative dose of opioids within the first year of life across all hospitalizations, calculated in oral morphine milligram equivalents. And our primary outcome of exposure was Bayley scales of infant and toddler developmental scores assessed at greater than or equal to 18 months of age. Our correlation coefficient showed a weak to medium relationship between total MMEs and Bayley cognitive, motor, and language scores. The table displays shows the results of our multivariable linear regression, which showed the impact of cumulative opioid exposure quartiles on Bayley cognitive scores. As you can see, within the third and fourth MME quartiles of exposure, there is decreased Bayley cognitive scores by 6.25 and 7.06 points respectively. Additionally, presence of a neuromuscular comorbidity and greater than or equal to 3 complex chronic conditions were also associated with increased risk of Bayley cognitive scores. We had similar results when we examined Bayley motor and language scores. In summary, increasing opioid exposures were associated with worsening neurodevelopmental scores at greater than or equal to 18 months of age. This relationship was significant within the highest third and fourth quartiles of opioid exposure, and it was significant even when adjusting for clinical severity, including prematurity and neuromuscular comorbidities. Our findings underscore the importance of judicious use of opioids within high-risk infants, and larger studies are needed to further adjust for additional confounding comorbidities. Thank you so much. I'd be happy to take any questions at this time, if there is time.
Thanks for a great presentation. One quick question. Have you been able to correlate any of this with clinical developmental outcomes?
Yeah, so the Bayley infant and toddler developmental scores you're talking about clinical outcomes from
behavioral assessments.
Yeah, and so that is our tool that we're using for behavioral assessment. So it encompasses motor, language, socio-emotional development. So it's kind of an all-encompassing score that our developmental pediatricians calculate at follow-up.
Great, thank you.
Yeah, you're welcome.
Okay, our next talk is going to be about fertility preservation choices in transgender and non-binary adolescents and young adults, and it's going to be presented by Dr. Catherine McKennelly from Lurie Children's.
The Endocrine Society and World Professional Association for Transgender Health emphasize the importance of discussing fertility and potential preservation options before initiating gender-affirming hormone therapy. This can include surgical options. We have observed an increasing interest in fertility preservation among transgender and non-binary adolescents and young adults and their families at our center. Here, I present a study on our center's experience in counseling these individuals on fertility preservation. Through a retrospective review, we examined the records of transgender and non-binary individuals referred for fertility preservation and counseling at Lurie Children's Hospital between September of 2021 and August of 2023. The majority of those referred to our program were white and identified as transgender, with half identifying as transgender male and about 40% identifying as transgender female. 3/4 of individuals completed fertility counseling, but only 17% of those with ovaries and 44% of those with testes completed any form of fertility preservation. This difference was significant. Importantly, however, in this cohort, there was at least one patient that used each fertility procedure option available to them. Our cohort's interest in fertility preservation prior to initiating hormone therapy underscores the importance of comprehensive counseling. This cohort utilized every fertility preservation option available to them, including experimental options. However, there's a gap between the observed interest and uptake of fertility preservation procedures. This highlights the need for further research and support to tailor the discussion about fertility preservation to transgender and non-binary adolescents and young adults. Thank you, and I'm happy to take any questions.
We have time for one quick question. At what point do you think in their gender-affirming pathway would you be able to implement this counseling?
So the discussion about initiating any form of gender-affirming hormone therapy begins at can only be considered after any of these children have shown any sort of initiation of puberty, so Tanner stage 2 at least. The majority of our children are already at Tanner stage 5 by the time they're referred to us. So we're seeing these kids pretty late in their maturity, but we're having a lot of these discussions with kids that are as young as, preteens.
Thank you.
Thank you.
Our next presentation will be from Dr. Vore from Cincinnati Children's Hospital, who will be presenting surgical treatment of ovarian torsion in pediatric and adolescent patients. Does education change practice?
Thank you for the opportunity to present our work. We have no disclosures. Historically, pediatric surgeons were performing significantly more oophorectomies for ovarian torsion compared to pediatric gynecologists, who are more likely to perform an ovarian-preserving surgery. In 2018, the APSA Outcomes Committee did a systematic review and made recommendations regarding optimal treatment of ovarian torsion, specifically recommending detorsion and ovarian preservation over oophorectomy. We sought to evaluate how education at a national meeting, further CME, and a publication may have affected practice patterns in the management of pediatric ovarian torsion. The Pediatric Health Information System database was queried from 2007 to 2023 for patients less than 18 years of age diagnosed with ovarian torsion. Generalized linear mixed model was used to compare oophorectomy rates between pediatric surgeons and gynecologists before and after 2018. We identified 4,107 patients, age range of 0 to 18 years of age. And we found that the treatment for ovarian torsion was primarily provided by pediatric surgeons, 83% compared to 17%. We also found that oophorectomy rates for pediatric surgeons have significantly decreased from 37.4% before 2018 to 18.2% after 2018. In conclusion, ovarian torsion is primarily managed by pediatric surgeons. Oophorectomy rates have declined by 50%, likely in part due to ongoing education affecting practice. Thank you.
Thank you. We have time for one question. Any thoughts on other things that may have impacted that pretty dramatic change in practice over those years?
So I think we're seeing, when we looked at this per year, we actually see kind of a steady decline kind of over time. So I don't think that it was just this education effort. I think there have been other education efforts that have been really helpful. There have been some case studies that went out saying that it's safe to do detorsion and not oophorectomy. And so I don't think it was just this APSA presentation, but I think that this is a platform where a lot of pediatric surgeons can become more familiar with these.
Great, thank you.
Our next presentation will be by Dr. Amanda Fairs, a prospective evaluation of non-operative treatment bundle for gastrocutaneous fistulae in children, and she's presenting from British Columbia Children's Hospital.
Good evening, and thank you for the opportunity to present our work here today. We have nothing to disclose. We designed this project to prospectively study the efficacy of non-operative treatments and closure of gastrocutaneous fistulae in pediatric patients. This work is important because gastrostomy tube placement is a common procedure for pediatric surgeons, and many patients go on to develop persistent gastrocutaneous fistula and experience distress and require additional interventions. Approximately 1/3 of pediatric patients have persistent gastrocutaneous fistula after gastrostomy tube removal. Prior studies have found improved closure rates with non-operative therapies such as silver nitrate, tissue glue, and antacid medication. We hypothesized that applying a treatment bundle of these therapies at the time of gastrostomy tube removal would improve fistula closure rates. We designed a prospective, multi-center, pragmatic study to test this hypothesis. Providers administered silver nitrate, a bioadhesive of their choice, and an antacid medication, either a proton pump inhibitor or an H2 blocker. Patients were treated at the time of gastrostomy tube removal and then assessed in person 2 weeks after, with repeat treatment applied if the fistula persisted. They were then reassessed at 4 weeks for fistula closure. Patient comfort at each visit was measured qualitatively, and our primary outcome was fistula closure at 4 weeks. We collected 100 patients based on a power analysis aimed to demonstrate a 50% reduction in the fistula rate. The mean age of the patients in our cohort was 6.2 years, and the mean time of gastrostomy tube was 3.7 years. At 2 weeks, 41% of the fistula had closed. At 4 weeks, 51% had closed. This is lower than the historical closure rate of 67%. From the qualitative patient data, we found that 35% of patients reported discomfort with silver nitrate application. So from this, we conclude that a treatment bundle of non-operative treatments administered at the time of gastrostomy tube removal did not improve fistula closure rates, and our application of silver nitrate caused discomfort in approximately 1/3 of patients. So based on these results, we cautioned against the use of silver nitrate for this purpose. Thank you.
We have time for one question. So given these results, what would you recommend?
So now that we've completed sort of enrollment for the study, we're still discussing the various options that are available with families, but are providing them with this information of what we found, that it didn't seem to make a difference, but it did potentially cause some discomfort. So we still offer it, but it's more of an informed discussion with families.
Thank you.
Okay, our next speaker will be Dr. Pediatric from the Johns Hopkins Hospital in Baltimore, who will be presenting postoperative outcomes in trisomy 21 infants undergoing esophageal atresia repair, a national propensity score matching study.
Good afternoon, everyone, and thank you for the opportunity to present our work. We have no disclosure. So trisomy 21 present unique challenges in surgical interventions, especially in esophageal atresia repair due to vectoral association. Our study aims to compare the postoperative outcome of patients undergoing esophageal atresia repair with trisomy 21 to those without trisomy 21. In order to do that, we conducted a retrospective review using the NSQIP-PEDS database from 2012 to 2020. Patients undergoing esophageal atresia repair plus or minus TEF were included. We compared the 30-day postoperative mortality as well as the 30-day postoperative complications between patients with trisomy 21 to those without trisomy 21. 2,380 patients were identified. 59 of which had trisomy 21. Patients with trisomy 21 were more likely to be older at the time of surgery and less likely to be male. There was no difference in the rates of cardiac risk factors between the two groups. On propensity score matching, we can see that patients with trisomy 21 had a higher likelihood of developing venous thromboembolism requiring therapy post-surgery, and they had a higher 30-day post-operative mortality rate. However, the rate of overall complications was the same between the two groups. Then we conducted a multivariable analysis, and we found that trisomy 21 was an independent predictor of 30 days post-operative mortality. Additionally, the presence of severe cardiac risk factors increased the odds of mortality by 800% compared to those with no cardiac risk factors. In conclusion, trisomy 21 is associated with an increased 30 days mortality after esophageal atresia repair. Additionally, severe cardiac risk factors were identified as the primary modifiable contributors to postoperative mortality. Therefore, our study shows the importance of assessing and addressing cardiac risk factors preoperatively while treating patients with esophageal atresia with trisomy 21. Thank you very much, and I would be happy to take any questions that you have.
Thank you. Yes, we have time for one question.
Agostino Piero, Toronto. Thank you very much. Very interesting data. Do you have data how many became eating orally without the help of a gastrostomy in this population?
Thank you very much for your question. So we only have, the NESQUIPEDS data only has data up to 30 days post-operatively. There's, I think, one variable that looks at TPN if given after surgery. However, we haven't looked at it yet, and we will be doing this in the upcoming
Thank you very much.
Thank you very much.
Thank you.
Thank you.
Okay, next we'll be hearing about the intercostal cryoablation and minimally invasive repair of pectus excavatum, national temporal trends and predictors of utilization by Dr. Alyssa Green from Johns Hopkins All Children's Hospital.
Good evening, and thank you for this opportunity to present our research today. A major issue associated with minimally invasive pectus excavatum repair has been pain control postoperatively. Utilization of intercostal nerve cryoablation has been shown to be a good pain control option and can reduce the amount of opiates needed postoperatively. Despite this data, some insurance providers still view it as an experimental procedure. The aim of our study was to quantify cryoablation adoption practices over time and evaluate predictors of its use. Our hypothesis is that cryoablation use has increased over time and that there are predictors of its use. The FIS database was queried for patients aged 9 to 21 years old who underwent minimally invasive pectus excavatum repair between January of 2016 and June of 2023. The groups were stratified based on cryoablation versus no cryoablation, and trends in utilization were described. We then compared both groups based on the covariates listed below. As you can see from the graph, there has been a positive linear correlation in the percentage of cases utilizing intercostal nerve cryoablation over the study period. A total of 2,068 patients fit our inclusion criteria. There were no significant differences in demographics. Median length of stay was significantly shorter in the cryoablation group, and the cryoablation group also had significantly fewer surgical complications. The no cryoablation group had lower total hospital costs. We found hospital volume and commercial HMO insurance type to be predictors of cryoablation utilization. This contemporary study shows rapid adoption and frequent use of cryoablation, particularly in high-volume centers. With this widespread adoption, cryoablation can be considered a standard adjunct in pectus excavatum repair. Thank you again for your time and attention today. I open up the floor for any questions.
were there any differences that you saw in pain control regimen aside from doing cryoablation versus no cryoablation in these patients? What was the pain control regimen? I'm sorry? Did you do a different pain control regimen, or was it just cryoablation versus no cryoablation?
We just did cryoablation versus no cryoablation. We did look at other pain control regimens, but the FIS database didn't give us really granular data on those factors.
Thank you.
Our next presentation will be from Dr. Sailors, who's coming from Children's Mercy Hospital in Kansas City. He'll be presenting an analysis of early patient-driven return to activity after NUS repair of pectus excavatum.
Thank you for the opportunity to present our work on a patient-driven early return to activity after NUS repair. Oh, sorry. We have no disclosures for this talk. Traditionally, at our institution, patients were given 3 months of a graduated activity restriction after NUS repair, including limited physical activity and no lifting of weight greater than 25 pounds. We wanted to evaluate if these traditional restrictions were misaligned with modern improvements in surgical technique, with the hopes that an earlier return to activity driven by patients would be safe and decrease morbidity. So we completed a single institution retrospective study from May of 21 to May of 23, looking at all patients that underwent thoracoscopic NUS procedure, and all these patients were instructed at 2 weeks post-op to return to physical activity as tolerated with no other restrictions. We wanted to evaluate any postoperative complications with our primary outcome looking at evaluation of any bar displacements. We had 81 patients that were enrolled in this study with a median age of 15 years and a median Haller index of 4. Almost 80% of patients had stabilizers placed during surgery, and our median length of stay was just over 24 hours. Our median time to our first follow-up in clinic was 24 days, and we found that almost half of patients at that time reported that they had returned to full activity. We had no episodes of bar displacement and no reoperations for bar adjustment or removal. So to conclude, patient-driven return to activity 2 weeks after minimally invasive repair of pectus excavatum is safe, and this allows our patients to return to activity earlier than our prior restrictions without an increased risk of bar displacement. This study warrants future investigation into more specifically what activities these patients are doing. Thank you. I'll take any questions.
Thank you. We have time for one question.
I just comment, I appreciate studies like this. For over 20 years, I've been using what I think is a very liberal lightening up of restrictions. I let patients go back to full activity after 6 weeks. Anywhere else I check, it's always 2, 3 months, even longer. Some people say no contact for while they have the bar in place. So in 2 decades, I've not seen or had any regrets about letting patients go back by 6 weeks after pectus repair, so thank you.
Thank you.
Yes, hi, Frank Margaro from CHKD. Question, what system are you using primarily for the pectus repair? Is it the Zimmer Biomet system or one of the other systems with lateral stabilizers? And number 2, how many of those were multi-bar repairs versus a single bar?
So all patients were single bar repairs, and they varied between 1 and 2 lateral stabilizers. I'd have to double check the specific bars and technology that we use.
Okay, and what percentage received cryo?
All these patients received cryo.
Thank you.
Mm-hmm.
Thanks for your question and presentation. We'll move on to the next speaker.
Next, we'll be hearing from Dr. Michaela Carter regarding the optimized outcomes following surgical correction of pectus excavatum based on medial clavicle epiphyseal ossification and white light scanning from Lurie Children's.
Thank you for the opportunity to present. Optimal timing of surgical correction of pectus excavatum is prior to complete skeletal maturation. However, at present, measures of skeletal maturity are not considered in routine preoperative planning. Therefore, age is used as proxy. The medial clavicle develops a secondary epiphyseal ossification center during a patient's adolescence. This goes through a process of growth and remodeling prior to complete fusion in a patient's mid-20s. The Schmeling-Kellinghaus classification system stages this process based on the medial clavicle's appearance on imaging. And we previously demonstrated that a patient's SK stage at time of surgical correction is predictive of their postoperative pain. We performed the present research in order to determine if a patient's skeletal maturity at time of surgical correction of pectus excavatum is predictive of two outcomes: postoperative complication rates and the improvement in deformity achieved. Patients with CT scans performed within 6 months of surgery were retrospectively identified. Their SK stage was determined from the CT scan, and postoperative complication rates were compared across stages. We then performed a subset analysis for patients who had preoperative and postoperative white light scans. Using their white light scan measurements, as well as the patient's demographics, a bootstrap forest classifier was able to predict the patient's preoperative and postoperative Haller indices and correction indices. Using this, we were able to determine the improvement in correction achieved, and this was compared across SK stages. In total, 61% of patients were stage 1, while 20% were stage 2, and 19% were stages 3 through 5, with the demonstrated age distributions. There was no difference in postoperative complication rates across SK stages. On subset analysis, there was significantly greater improvement in the Haller index for SK stages 1 and 2 as compared to SK stages 3 through 5. The same was true for the correction index. Skeletal maturity should be considered rather than age when determining the optimal timing for surgical correction of pectus excavatum. An intervention during SK stages 1 and 2 may optimize outcomes for this patient population. I'd be happy to take any questions.
Are there any other benefits that white light scanning would offer aside from decreased ionizing radiation, or how would you implement that in your clinical practices?
Yes, that's exactly why we're interested in white light scanning, because it is a non-ionizing alternative. And so it enables us to evaluate that improvement post-operatively, because the CT scan is not obtained post-operatively right now, and we don't want to expose these children to an extra dose.
Thank you.
Thank you.
Our next presentation is from future Dr. Young, who will be presenting delayed cholecystectomy in the pediatric sickle cell population is safe. She's coming from Numerous Children's Health in Florida.
Good evening. Thank you for giving me the opportunity to present our work. Special thank you to Dr. Taryn McMunkle. Here are my disclosures. None are relevant to this presentation. The sickle cell disease population is at increased risk for cholelithiasis and vaso-occlusive crisis during illness and after procedures. We sought to evaluate the morbidity of delayed cholecystectomy in this patient population. We learned that delaying surgery in sickle cell disease patients with complicated biliary disease is safe and associated with decreased hospital length of stay and charges without an increase in ICU admissions, complications, or vaso-occlusive crisis, and therefore should be considered. We conducted a retrospective chart review of children with sickle cell disease who underwent cholecystectomies in our healthcare system from 1998 to 2022. 155 patients were divided into 4 categories: non-complicated versus complicated biliary disease who underwent elective surgery versus semi-urgent surgery. Disease severity and urgency of surgery were associated with an increased length of stay. There was no statistically significant difference in length of stay for patients who underwent elective cholecystectomy. Length of stay for patients with complicated biliary disease who underwent delayed cholecystectomy was shorter than those who underwent urgent cholecystectomy. Hospital charges were significantly higher in semi-urgent cholecystectomy for complicated and non-complicated biliary disease. Of those with complicated biliary disease who had delayed cholecystectomy, 2 patients, 10.5%, experienced at least one associated readmission prior to surgery. There was no difference between ICU admission rates, postoperative complications, or the incidence of postoperative vaso-occlusive crises. In conclusion, delaying cholecystectomy in sickle cell disease patients with complicated biliary disease is safe and should be considered. Here are my references, and I'll take any questions.
Thank you. Can you comment a little bit more about the rate of transfusion in uncomplicated elective cholecystectomies? Was that pre-op optimization, or what did your group think?
Right, so it's pretty standard at our institution for hematology to request preoperative transfusion in uncomplicated elective surgery. But what we found very interesting is that if you look at the transfusions rate, it doesn't go as predicted. And so we definitely need to look more at this data and do some further analysis. We suspect that there is some maybe practice pattern difference in the northern part of our health system and the southern part, and so we would like to look more into that.
Thank you. And one quick question?
Very quick question. Thank you for your presentation.
Thank you.
Did you look at the complications related to the sickle cell disease post-operatively too?
So the only thing we looked at specifically, thank you for your question, was vaso-occlusive crises. And there was no statistically significant difference in the in complicated or uncomplicated for elective or semi-urgent.
Okay, thank you.
Thank you.
Next, we'll hear from Dr. Emily Ness regarding the prevalence and predictors of gallbladder disease and pediatric intestinal failure from Boston Children's.
Thank you for the opportunity to present our work. I have no disclosures. Intestinal failure has been associated with an increased risk of gallbladder disease. Historically, prophylactic cholecystectomy has been considered. However, there is a lack of data in the present era of hepatoprotective PN strategies and increased patient survival in pediatric intestinal failure. This paucity of data is the reason why I researched this topic and why I'm here talking to you today. The aim of our project was to identify the current prevalence of gallbladder disease and the independent predictors in this patient population. We performed a retrospective cohort study at our intestinal rehabilitation program from 2014 to 2021. Patients included in the study had a diagnosis of intestinal failure defined as PN dependence for at least 60 days within a 74 consecutive day period and had an abdominal ultrasound at our institution. Abdominal ultrasounds were obtained annually, and all ultrasounds during the study period were included. The primary outcome that we evaluated was the presence of gallbladder disease defined as cholelithiasis or sludge on ultrasound. Multivariable logistic regression was used to identify independent predictors of gallbladder disease. Of the 268 patients who met inclusion criteria, 87 or 32.5% had gallbladder disease. Median length of follow-up was 4.7 years, and the cholecystectomy rate in patients with gallbladder disease was 18.4%. Risk factors associated with the higher odds of gallbladder disease included current PN dependence and male sex. A diagnosis of midgut volvulus was associated with the lower odds of gallbladder disease. In conclusion, 1/3 of patients had gallbladder disease. PN dependence or male sex doubled gallbladder disease odds, while a diagnosis of midgut volvulus lowered odds by 61%. Fewer than 20% of patients with gallbladder disease had a cholecystectomy, suggesting that expectant management is a reasonable initial strategy, though long-term monitoring is necessary. I'd like to acknowledge those listed for their help and support in this project. Thank you for your time. I'd be happy to take any questions.
Okay, we have time for one quick question. So given these results, how would you advise patients and their families?
We would recommend if they do have gallbladder disease to wait, and we would follow them long-term, since many of them had expected management and did okay.
Thank you.
Thank you.
Our next presentation is from Dr. McCauley from Lurie Children's Hospital in Chicago. We'll be presenting specialized tissue processing methods for prepubertal ovaries following oophorectomy for fertility preservation.
Thank you for the opportunity to present our work. I have no disclosures. 15,000 children are diagnosed with cancer in the United States each year. However, with a 10-year survival rate of 75%, the most likely outcome for these children is survival to adulthood. Despite life-saving treatment, some patients will develop infertility as a result. Ovarian tissue cryopreservation is the only fertility preservation option for young children. We did this research to help clarify differences in OTC techniques for these young patients. OTC requires laparoscopic unilateral oophorectomy and processing of the ovary into cortical strips, with the goal of eventually reimplanting these strips to restore fertility and hormone production. OTC techniques were developed in adult ovaries, with some centers producing very thin cortical strips of 0.5 millimeters, which is not well suited for pediatric ovaries. The ovary in a young child is very different than the ovary of an adult. Specifically, primordial follicles or potential eggs extend deeper within the prepubertal ovary than the postpubertal ovary. This is demonstrated by the green arrows. If adult processing techniques are used for pediatric patients, potential eggs will be discarded. In this work, we sought to demonstrate important differences in processing of the ovary for pediatric patients. We evaluated tissue processing metrics for 66 children. Here, we see age at time of OTC on the x-axis and percent of ovary preserved on the y-axis. As age increases, a smaller percent of the ovary is preserved. This is what would be expected given the anatomical differences of the developing ovary. Patients and parents frequently ask how many cortical strips are preserved. Essentially, this represents the individual opportunities for ovarian tissue transplantation. The number of cortical strips preserved increased linearly with ovarian cross-sectional area and by pre-processing weight. For prepubertal patients, the median number of strips was 5, and this number increased linearly with size of the ovary up to 20 in some older children. In conclusion, a greater percent of the ovary should be preserved for younger children in the form of cortical strips up to 2 millimeters thick. This will maximize the number of potential eggs preserved. I'd like to acknowledge the members of our team, and I'd be happy to take any questions.
Thank you. We have time for one question. Were there any other technical tips or pearls you can offer based on your research, short of the size or the number of strips?
Yeah, I think overall, our perspective is that pediatric ovaries should be processed at a pediatric center, given the familiarity. And the main tip that we would offer is the maximum amount of tissue that is possible to be preserved should be preserved. So the medulla is overdeveloped in postpubertal patients, so the opportunity for preservation is smaller, but everything that can be preserved safely should be.
Great, thank you.
Thanks.
Next, we will hear about the oral delivery of CNP MIR 146A reduces TNF in a murine model of inflammatory bowel disease by Dr. Anisha Ept from the University of Arizona.
Thank you for the opportunity to present our research. Here are our following disclosures. So Crohn's disease is a form of inflammatory bowel disease with no cure that is commonly diagnosed in childhood and is associated with growth failure, shortcut syndrome, and a threefold increase in mortality. And novel therapies are needed in Crohn's, given that current available therapies are often associated with pretty severe side effects, usually due to systemic delivery, as well as they are ineffective in around 30% of the population. We have developed a nanoparticle called CNP-MIR146A that has both anti-inflammatory and antioxidative properties, and we sought to investigate its therapeutic use in an animal model for Crohn's disease using oral delivery. CNP-MIR146A consists of a cerium oxide nanoparticle, which is a potent free radical scavenger, that is conjugated to a small non-coding microRNA, microRNA-146A, which is an inflammatory regulator that works by inhibiting the NF-kappa B pathway's activation. We chose to utilize an adoptive T-cell transfer model in which RAG2 knockout mice receive donor-naive T-cells, which induces a Th1-like response in the colon, similar to Crohn's disease. We determined whether mice had colitis based on elevated fecal lipocalin-2 levels following T-cell transfers, and then randomized mice to receive 5 days oral gavage of either saline or a nanoparticle. Tissues were collected at the end for molecular and histological analysis. What we found is that mice with T-cell transfers who received PBS showed marked elevations in TNF, which is a marker of inflammation, in both their proximal and distal colons, as seen by the red bars on this graph, compared to controls in the blue and purple, and this was true for both gene and protein analysis. Meanwhile, mice that received our nanoparticle, as represented by the green bars, showed significant reductions in TNF in their proximal and distal colons. Additionally, looking at CD45 immunohistochemistry, we found that mice that received our nanoparticle showed far less leukocytic infiltration, as seen on the image on the bottom, compared to mice that received saline, as shown on the image on the top. So in conclusion, we found that CMP-MER146A represents a novel orally available therapeutic with the potential to reduce inflammation in IBD and high potential to advance into clinical trials. Thank you, and I'm happy to take any questions.
We have time for one question. Did your team appreciate any unwanted side effects when this was administered orally?
Can you repeat that?
Did you see any unwanted side effects when this was administered orally?
We did not necessarily see side effects. It's only a 5-day course. We have done toxicity studies with our nanoparticle in rats, and we haven't seen any significant abnormalities in any of the organs or serum. But I think longer studies looking at longer duration and higher doses are in order.
Thank you.
Thank you.
Our next speaker is Dr. Huerta from the University of Miami. We'll be presenting Association of Necrotizing Enterocolitis and VP shunt failure in neonates, a nationwide analysis.
Thank you for the opportunity to present our work today. We have no disclosures. We undertook this research given the prior concerns about ventriculoperitoneal shunt creation in neonates with intestinal comorbidities such as necrotizing enterocolitis have been raised in the past. This research is important as a method to characterize risk factors and outcomes associated with VP shunt placement in neonates with a prior history of NEC, given that prior studies have suggested NEC to be associated with a higher rate of VP shunt-associated complications, but have been limited by their single institution study design and low number of patients sampled. Therefore, we queried the nationwide readmissions database, which is the largest inpatient database capable of tracking hospital readmissions in the United States, over a 4-year period for neonates with necrotizing enterocolitis who subsequently underwent VP shunt creation in the same hospitalization. We identified 522 neonates with necrotizing enterocolitis compared to a cohort of over 24,000 without NEC that underwent VP shunt creation, and found that neonates with NEC had a somewhat higher rate of VP shunt-associated complications, including shunt removal, as well as conversion to ventriculoatrial or pleural shunt placement. However, to also account for other factors that could explain differences observed between both cohorts in our univariate analysis, we constructed a binary logistic regression utilizing 30 covariates, including perinatal conditions and comorbid diagnoses, to examine a primary outcome of VP shunt removal, and found that necrotizing enterocolitis still persisted as an independent risk factor associated with a higher odds of VP shunt removal in these patients. Ultimately, neonates with NEC in this database who undergo subsequent VP shunt placement experienced a higher rate of some VP shunt-associated complications, including shunt removal, as well as conversion to other terminus sites for their ventricular shunt, as well as higher overall readmission rates. And future studies are needed to better delineate and optimize what factors can be improved for patients with NEC that require VP shunt placement. Thank you.
Thank you. We have time for a question.
Hi, I'm Priyanka, Surgical Research Fellow at Boston Children's. Are you able to tell with this database the time delay after their episode of NEC, and was it medical NEC or surgical NEC?
Yes, thank you for that question. So we didn't have time to put it in our presentation today, but we have also stratified based on those who underwent surgery, and NEC still persisted as, even without abdominal surgery, persisted as a risk factor for VP shunt removal and some other complications. In terms of the time delay, that's something we're still continuing working on. We are able to do that with the newer version of the nationwide readmissions database, but something that we'll be exploring in our future manuscript.
Thank you.
Thank you.
Thank you.
Lastly, we'll be hearing from Dr. Colleen Fitzpatrick regarding the comparison of climate impacts, clinical outcome, and cost efficiency of pediatric transumbilical laparoscopic assisted appendectomy versus standard 3-port laparoscopic appendectomy from Cohen Children's.
Thank you for the opportunity to present. We have no disclosures. Why are we doing this research and why is it important? Anthropogenic carbon emissions have been increasing since the Industrial Revolution, resulting in a changed climate that will persist for generations. Furthermore, the U.S. healthcare sector is responsible for a significant proportion of national emissions. As such, every healthcare intervention has both short and long-term consequences. If, as pediatric surgeons, we are truly in the business of saving lifetimes, we must consider climate impact when making decisions. This study seeks to compare clinical outcome, cost efficiency, and climate impact for the single-incision transumbilical laparoscopic assisted appendectomy versus the typical 3-port laparoscopic appendectomy. A 3-year retrospective review was conducted, patient characteristics and clinical outcomes were compared, operative data on instruments and supplies were collected, cost efficiency was determined using supply costs, and a cradle-to-grave life cycle analysis for back table supplies was conducted to determine climate impact. 497 patients underwent a primary 3-port laparoscopic appendectomy. 1,114 started off with a transumbilical single-incision approach. However, 182 of these were converted to the 3-port approach. No cases were converted to open. Since the converted cases started with a single-incision approach, the single-incision and converted cases were grouped together for this analysis and are listed under the heading of single plus C. There were no clinically significant differences in outcomes. Specifically, the transumbilical approach did not result in an increased rate of surgical site infection. The single-incision transumbilical approach alone is the most cost-efficient and has the smallest carbon footprint. When combined with converted cases, the cost efficiency and carbon footprint are still superior to the 3-port operation. This study is unique in its approach of tying clinical outcomes together with environmental impact. Given the non-inferior clinical outcome, but the better cost efficiency and climate impact, consideration should be given to performing appendectomies via the transumbilical approach. Thank you, and I'll be happy to answer any questions.
Barath Nath from Virginia. How do you estimate the carbon emissions from varying pieces of surgical equipment? Just what's the technique they use?
So the life cycle analysis, it's a cradle-to-grave assessment. So, for example, if you take a monocryl suture, you weigh the suture, you estimate that it's derived from mixed plastics. There are emissions factors that give you the amount of carbon per weight. You then weigh the box that the monocryl comes in. You figure out how much of that box is attributed to the monocryl. There's an emissions factor for the cardboard. And you go through this for the shipping boxes. You have emissions factors for the distance that a product travels based on the mechanism of the travel. There's inbound transport, outbound transport, and landfilling. So the emissions factors exist in published databases. And so it's a matter of figuring out how much of each specific material you're using and then tracing it from inception to landfill or recycling, depending on what the disposal approach is. This study was based on assuming everything went to landfill. We didn't have any specific recycling in the study.
Thank you.
Thanks, and this concludes.